Hi, welcome everyone. I'm the cleanup hitter here, I guess. And so I want to talk to you a little bit about stuff that in the real world is fairly laid out on that adoption curve, but really for us in medicine probably is more at the hype stage. Okay, and that's the mobile, wearable, Internet of Things, and all this sort of stuff, and how it's going to impact what it is we do. I don't have any financial relationships, or at least that was true when I made the slide. As of Friday, I am now Mandel Anesthesia Innovations, LLC. It doesn't bring me any money or any conflicts of interest, but full disclosure. Okay, and I'm not going to talk about any off-label or investigational use because, hey, this stuff is all off-label. We're not supposed to be using it in medicine, or maybe we should. Okay, so what are some goals? I want to present some technology that's available right now in consumer gadgets. Everything I'm going to talk about, you can go out and you can buy yourself. It's all consumer off-the-shelf technology, and of course none of it is FDA approved. Okay, I want to discuss how this data is being collected and whether that serves as an impediment to us being able to use it in clinical medicine. Okay, and then speculate on what the impact of this is going to be on our specialty and the broader practice of medicine. Okay, and so as Kai mentioned, I run a little thing called the STA Engineering Challenge every year. It's an annual event at the STA meeting, which is always in January, hopefully always someplace warm. We're going to be in Austin in 2020, which, depending upon how the cold fronts move through, it could be balmy or it could be freezing. But nonetheless, if you don't have anything better to do in January, I strongly endorse you coming down to Austin for some Texas hospitality and a lot of fun with engineering. Okay, it's open to students and trainees. Okay, so if you've got a resident, a medical student, an engineering student, or somebody like that, and you want to pair with them and enter, you can do that. It's focused on emerging technology and gadgets. It's a lot of fun, and these are not really FDA-approved devices, and we have prizes. Best thing about it. Okay, and so I'm going to sort of tie in some of the things we've looked at in the engineering challenge to where I think the field is going to be going in terms of incorporating these consumer electronic devices into the practice of medicine. And so one of the big concerns we have right now is understanding functional status. Okay, and frailty is associated with poor anesthetic outcomes in octogenarians. This has been studied. We understand this. Okay, and prehabilitation may improve perioperative outcomes. This has been studied. The data on that is not quite so good, and we'll get to that in just a second, okay? But how do we really measure frailty, okay? We may know it when we see it, but what we'd really like to do is not see it when the patient walks in the clinic, but be ready for it on the basis of what we can learn about what's going on in their day-to-day life, okay? And we can look at the record, and the problem is much of this data is still on paper, and as Jim Phillip and another past president of the Society for Technology and Anesthesia says a picture is worth 1,000 words, but a picture of 1,000 words is worth very little. And so if you're trying to deal with an octogenarian and go back into their medical record, you've got to deal with the fact that a lot of this stuff is on paper, and it's not really particularly useful. And I work a lot in the GI Endoscopy Center. In fact, I pulled my case log for the last 2 years. I saw 7,500 patients in the last 2 years. I can't possibly go through paper records to know what's going on with this patient that's coming in. And so can gadgets help? Number one, can I get grandma to wear a wearable device? Well, as it happens, my 96-year-old father has an Apple Watch, okay, and an iPhone, and so maybe I can get some data from him. What can I measure with these devices that's going to be useful to me in trying to come up with an assessment of frailty? And what do we need? What do we need wearables to be able to get what we need here? All right. So, and then most importantly, how do we get access to this data? okay? Because this data is not in any sense of the word what we consider to be protected health information, and how do we make it into protected health information, okay? So what can we measure with a watch? Well, we can do an awful lot. Even this is my first generation Apple Watch that I inherited from my 17-year-old who wouldn't be caught dead in public wearing a first generation Apple Watch, but it's okay for his dad, the technology geek, to be wearing. But with this, I can get a 9-axis accelerometer. I can get optical heart rate. If I get one of the new ones, I can get continuous EKG. Not necessarily off of this one, but I can buy wearables that'll give me saturation. I can get galvanic skin response. I can get skin temperature. And there are other things as well that we can get, or we will be able to get. We will be able to get transcutaneous estimation of glucose, a whole lot of things like that. It's a lot of information that's out there on these watches, okay? The problem is that if you go to Apple or you go to Google or you go to any of these companies and say, how do I get access to that data off of this patient walking in, you find out that there's a problem with this because they are not a covered health entity, okay? So under HIPAA law, there's no way for them to share this information. I had the privilege of taking care of a sitting U.S. representative, and we were went to see him post-operatively, and I said something, oh, say hi to this person. I said, well, sir, I can't tell them I took care of you. That's protected under HIPAA. He says, oh, yeah, HIPAA. Well, the worst ideas I ever had. You know, it's just like, oh, okay. Gives you a different perspective on this. Okay, so, all right. So in 2015, we did for the engineering challenge, we used smartwatches, and the challenge was to come up with a way to measure what the difference between an easy and a difficult intubation was. Okay, now this is fairly easy to do because after all, I can get a simulation mannequin that I can put a setting on, easy or difficult. So I can standardize this task and I can look at something that's going on in the watch, and off the accelerometer, people could get a reasonably good indication of whether this was easy or difficult. And what is this useful for? Well, one aspect of this is I might want to know that you as a patient are the hardest intubation I've done this year. This might be useful information that I would put into the blockchain records so that when you come into another healthcare provider, they're prepared for that. But the other thing I might want to know is that, boy, over time, I'm really having to work harder and harder to intubate, and maybe I should ask my older self how I've been doing on my retirement account, okay? So there are things that we can discover by biometrics about our patients and about ourselves if we can do that. Do we need a watch to do this sort of stuff? Well, no, we don't. We can get head-mounted devices. We can look at gaze. We can come up with various ways of getting this information. There are pendants you can wear. There are commercially available pendants that can tell you what your fall risk is based off of actinography. There's footwear. You can buy Nike shoes now that'll tell you something about your gait, that will tell you, has your gait degraded to the point that now maybe you're at risk for falls, okay? There are biometrics you can get. There are things you can do to analyze your keystroke patterns that can look at your speech and can start to tease out some of these frailty effects. There are Internet of Things devices that you can buy that can give you this information. And so we looked at some of this stuff in the engineering challenge in 2016. There's this device here called the emotive headset. I don't know that anybody's seen this. I've got a nice picture of Jorge Galvez wearing the one that he won in 2016. But it's a dry contact EEG headset that communicates over Bluetooth. And the challenge for 2016 was to develop a system that could detect the EEG change that occurs when an anesthesiologist hears a pulse oximeter drop below 85%. Okay? And the thing is that if you're in a room of people and you play that sound, boop, 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 you will know who the anesthesiologists are, okay? Even if it's in the background, it provokes a neural response, okay? There are other things you can track. You can track driving performance. This is something called DriveWell that you can buy, or in fact, you don't even have to buy it. Your insurance company will get it for you. State Farm will provide it. And it will measure your acceleration and braking over places you've been before, and it's got incentives to lower your insurance rate based on how you drive, okay? Maybe you want to know that your ride from the ASC is here to pick you up. Okay, there are smart chairs that you can get. This is a chair you can buy from Herman Miller, I think, and it's got multiple sensors and it can tell how much you're slouching. Okay, maybe we want to know about things like that to know that what's going on. It's got tactile feedback and data in the cloud. So now the question is, where is that data? But one thing we know is you don't own that data. Okay, as much as they might tell you that you do, you don't own the data. Apple may own the data. Google may own the data. Somebody else owns the data. And you have a click-through agreement that says, I don't own my data anymore. So how do we get that data? Well, we might be able to get the data from a vendor. They may accept our money to be able to get access to that data. But again, what is it that we have to do? And how do we associate that data with your medical record? Okay, I recently had about 90 seconds for an elevator pitch with the current U.S. Surgeon General, who's an anesthesiologist, and I told him about this problem. Okay, and this is a government regulatory process. So if you know your representative or your senator or anybody like that, this is something we need to work on, because we want a way to be able to get access to this data so that we know when we're getting frail. Okay, and so this comes back to the engineering challenge in 2018, which was the blockchain, which we heard a little bit about, and it was just to devise a system that could record an intubation difficulty score in a blockchain. In an intubation difficulty score, well described, you can put it into about 32 bytes. Okay, and so, so that was something that we were interested in, a way to be able to get this data out there. Okay, so how will this change what we know about our patients? Okay, well, number one, we can give patients incentives to improve their metrics. Okay, maybe if you know that that you've become increasingly frail, but you're coming in for surgery at some point in the near future, maybe you say, "Oh, I've got to get that metric up a little bit because I don't want to spend an extra week in the hospital." Okay, maybe we can have better ability to track decrements in performance after time, so we can associate quality outcomes with particular anesthetic interventions. Okay, and the ability to access data from patients who change jobs, insurance, and locations. Okay, also, how does this alter how we prepare patients? Okay, well, this is a study that just looked at the literature and said, how many studies have been done in assessing changes in outcome over time? And you see these. There's an increase in interest in this, but if you look at how many intervention studies are there are almost none. Okay, and this is what we need to change. We need to figure out how to get this information out of the cloud. We need to more objective measurements of procedure difficulty, ability to assess the impact of policy changes on our performance, and early warning of disability. And if we can get that out of these consumer devices, I think that we can hopefully make a change in how we take care of patients in the future. And I think that brings it in 15 seconds under schedule. And I think we're gonna have questions. I have to tell you, I've got to be on a plane in about 2 hours. So if anybody has questions specific for me,
run them first.
What?
We'll ask you first. Yeah.
Okay, all right.
So maybe we can ask our speakers to come on the panel, and maybe the first people have questions, address them to Jeff Mandel.
Uh-huh.
Any questions? There's somebody.
Hello. This is a great talk, a great panel. My name is Dr. Lana Gillian. I'm an anesthesia intensivist at UCLA Medical Center. I think this new technology has potential to expand the role of the anesthesiologist outside of the OR and outside of the ICU and outside of the hospital. And probably the most direct application that was mentioned was frailty and prehabilitation that can be done by pre-anesthesia clinics. But really what it is a mode of remote surveillance. So you're monitoring your patient for like a month, maybe a week before their operation, and getting quantitative mobility data on what they're doing. The real challenge here is actually implementing this into pre-anesthesia clinics. Who's going to look at that data? Who has the time to look at that data? What is the actionable intervention? At UCLA, we do have a prehab program that's being run out of our VA, and we do have a published study. But the next thing that we're doing is we're going to be putting wearables on our patients to actually do a pilot study and see if this is feasible, if this works, if we have staff to do it. On the back end of things, technologies like this really would apply well to high-risk patients, such as ICU survivors, or the patients who have really prolonged hospitalizations. When we send them out of the hospital, do they get back to the life that they had? Do they get back to their baseline? But again, we need to assess whether anesthesiology as a field can expand its role outside of the walls of the hospital, and if our field really wants to go there.
Yeah, thank you. Jeff, do you want to comment on that?
I'm trying to find the question in that, but okay. So yeah, and I think the key to this is that somebody is going to figure out something now, and it's going to have to be at this level, which will tell you that that your risk, your perioperative risk is going up on the basis of your lifestyle or going down on the basis of your lifestyle. So if I've got a fit specimen like Brian Rothman here, the current president of the Society for Technology and Anesthesia, who I know engages in a keto diet and an exercise program and stuff like that, if I'm monitoring him over time, and then all of a sudden there's a new Epic rollout, and he stops exercising, and he's up late eating Yoo-hoos and things like that. And so his smart app says, hey, look, Brian, you're kind of going to seed. And that planned cosmetic surgery procedure that you've got 2 months out from now, yeah, exactly, that your risk of a postoperative complication has gone from 0.1% to 10% or something like that, and you can look at that and you say, okay, that's the kind of nudge that I need. I don't need a doctor telling me, hey, you need to take care of yourself. But if I can see on the basis of objective data that my performance has dropped off, maybe that's the sort of stuff that pushes people into healthier lifestyles. Yeah. So Brian.
Brian Rothman, Vanderbilt. Great panel, fantastic content. I think one of the things that was brought up again was a lot of, and I'll build off the previous person who asked the question. One of the things that I've been looking at recently is that we have all this great technology. We may, even if you can get the information, I think the next question is when we talk about remote monitoring, there's no revenue stream. Who's going to catch the information? And if something critical happens, what is your level of responsibility to act on it? Even if you haven't yet, let's say someone's coming in for a preoperative visit, you set them up for a 7-day monitoring period, and it picks up an arrhythmia. What is going to be your level of responsibility, and how does it support the cost of the implementation of putting in this remote data? and collecting this remote data. So any thoughts on that, on how do hospitals actually operationalize this type of data collection and keep patients safe?
Yeah, thanks, Brian. Very timely question. I think we are on Epic, my institution, it's in Toronto, and just in the last few weeks and months, we've been reviewing some of the pre-op preparation of our patients and reviewed, interestingly, some of the integration of wearable devices, sending data right into the patient's EHR record using their application called MyChart. So it sounds as though the technology is not impossible. It's there. It's happening. We saw a demo of it. Absolutely, it works well. The question you bring is, I think, it's probably where we need the conversation to go, is certainly who owns the data, and when it comes into the patient's EHR, it sort of probably is the patient's data that we're getting. And I think the cost-benefit analysis, I'd say, is prevention in this case might be cheaper. It means, the less complications. The business rules and models, I think they're not fully elucidated yet. We're not great at preventive medicine in the Western world. We are more of, treating something that's happened. I think it's an opportunity for anesthesia, as mentioned, in the perioperative realm, to sort of begin to ask those questions and bring in models that show reduction in complications or, same-day cancellations, because such technology was a red warning or sent a signal timely to prevent a bad outcome.
I just want to add on to that, actually, is that the implementation and the uptake will probably be greatest and quickest in areas and in systems that are tracking their data and metrics. So the NISQIP hospitals, and you're talking of the systems that are much more conscious of the cost of their care and tracking the data around the cost of their care. Some of that's been incentivized by regulations, but it's not quite there yet in terms of for anesthesia when you have some of the quality metrics that we're looking at are stuff such as OR fire. Really, so I think as we get more towards the data-centric and cost-centric, with cost and quality and data all coming together over the next 5-10 years, that we'll be able to better elucidate the return on investment for these pre-op and these preventative technologies.
I'll just add on, I think it's not a new area. We have monitoring for ICDs. It's been happening for years now with phone calls when there's a problem and 911 go. So I don't think it's something that's new within medicine. There's some businesses that have done well in that. I think for anesthesia, it's probably new for us to think that way and bring in the right business model to support what we do with wearables in that manner.
And there is a difference in the business model, to add on to that, between those that are the remote monitoring technology and the remote recording technology. And so if you're monitoring in a 24/7 way and you're looking for events and you need to intervene on that event, as a business model, that's a much more expensive business model than those that do the remote recording, and then you're given a data stream back. And that's a whole fundamentally different business model.
Yeah.
And I just want to quickly add to that. So one of the things that also I think we need to pay attention, we have a similar study that we are looking at wearable data from older adults, and we are integrating that with Epic data. And one of the things that we realize is that it's very important to actually have the discussions regarding what pieces of data actually would be useful, because when you are recording data from an accelerometer, that is tons of data, and that needs to be presented in a very usable format. So one of the things that we did, we have the focus groups, semi-structured interviews with physicians, different backgrounds, to see what would be useful to them when the data is presented. And another thing is that I think also the use of analytical predictive models can also help to reduce some of the false alarm. But again, they need to be accurate enough to prevent some of the false positives that might be unnecessary.
Yeah. I'm going to take the contrarian view, which is I think that this is going to emerge out of the marketplace. And just like DriveWell, you don't have to sign up for DriveWell just because you have an auto insurance that uses it. You're given the opportunity to do this to reduce your insurance rates, okay? So I was trying to talk some people, as persuasive as I am unsuccessfully, into the notion that we just needed to, wouldn't it be neat if we could just have like one of these standing stair walkers and just measure, how much can you increase your heart rate, and is that associated with a lower complication rate in our GI endoscopy unit? Okay, and maybe if I can get that off of your biometrics and all, and say, yeah, you're okay to come in on Monday and Tuesday and Wednesday because that's when we're staffed with a model that can take care of healthy people like you, or no, you need to come in on Thursday and Friday when we've got a different staffing model, and the only thing is that your bill for this is going to be different. That sort of stuff is going to be much more feasible to work out, because you give people a clear economic incentive to change their behavior, or if they can't, to say, well, okay, we've got a care model that takes care of you.
Yeah.
So, Eric?
Just a quick comment about the usability. I think that actually touches on the medical legal impact or risk. And that's where you're going to see some resistance, where you try and take in the MyChart stuff, or if you try and take in granular data. If the data comes in a granular fashion, which is discoverable, and that's what your lawyers will tell you, and then it's not in a usable format, and even if it is, if it's missed, you become responsible. And that's what I talk about when I talk about infrastructure and responsibility. So just as a comment, I would say that the usability, the presentation of granular data in a usable format is going to be very important going forward to that business model.
Yeah.
Totally agree.
Thanks, Brian. Derek?
Yeah, thank you very much. Derek Sakata, University of Utah. So I am going to take it outside of anesthesiology because, like stated, we need to be more involved outside. So 8 months ago, I became executive medical director for all medical specialties. So I've got an emergency department, I've got primary care and other places. I have to measure something called EPE. Do you use this? Exceptional Patient Experience? Does that ring a bell to anybody? We measure how satisfied our patients are with our care. We also measure how well our clinicians are. Technology should not be an obstacle to us as clinicians to take care of patients. Example, primary care. I've got 12 metrics and I'm an anesthesiologist, right? 12 metrics I have to screen in my patients. One of them is depression scale score. And I cannot get my primary care clinics to get up on that. So I'm looking at how do you measure this. It would be nice to have a technology that actually looks at your patient and looks at their gaze, like was mentioned, and how they're walking, to sort of intrinsically take in these subtleties to understand what they're doing without me having to actually sit down as a primary care provider and scale and it's like, fill this out, do this. And there are numerous places. There are 12 things that we have to screen in primary care now to be up to speed on our patients. So technology like you're all proposing, which I think is great, please make it easier on all of us clinicians, whether it's in my ED, whether it's in physical therapy, all these providers need help. So thank you very much. And think about it from that realm, so it's outside of everybody.
But see, I think the marketplace will solve this for us, because you on your own don't have the economic leverage to deal with the problem of assessing whether people are depressed or not. Apple, Google, Facebook, all those people, they see tremendous economic opportunities in being able to come up with this sort of stuff, and enormous social good in being able to identify people who are depressed.
Yeah. Last question, Matthias. So we need to be closing down.
Well, thanks so much for this panel. I think it was fantastic. So Matthias Gerges, University of British Columbia. Given that liability and trust are the two things that are tricky moving forward, where do you think are the low-hanging fruits that we can actually move forward in putting something like this into practice?
I'll start with, I think I spoke on VR, so I'll focus on that. One is that it's consumer technology that a lot of people use and know. And there's some growing evidence for it improving various outcomes, depending on what you're measuring. Patient experience, also making training more distributable. And so I think that's a low-hanging fruit. We have released apps that are free, that have a framework that you can create your own VR content in your institution to improve patient experience or prepare them for procedures.
Great. I thank everyone here for your attention. It's been a fantastic panel. Thank you to the speakers, and thanks for IARS to letting us have this panel. Thank you.
Thank you.